either one of you, without putting you on the spot, what would fully funding your program mean to New York State?
As far as the program or as far as the dollars?
Either.
So I'll start, and if Alan wants to add anything. I mean, I think fully funding the program would look like every region of the state having registered opioid overdose programs, as well as the ability to respond. I think we heard from our member of the community who resides within a rural area that the challenges are significant as far as looking at these opportunities, whether it be through the prevention programs and or other forms of harm reduction support. And again, pointing to the full continuum as continued by OASAS. As far as funding, as you've seen, the expense around naloxone is about $13.5 million. That's in the most recent year. We have continued to see an increase each year. $8 million covers a portion of that. If we wanted to see not only sort of funding for what we've experienced to date, but in addition to an anticipation of increased purchase of naloxone, then we would be looking at increased dollars beyond the $13.5 million.
Alan, I'd love to hear your thought.
Yeah, and just in terms of, I mean, just support what Joanne said, to support it, fully fund us for naloxone, and at the growth rate we're going at, probably 17, 20 million just for the naloxone. But then there's all the,
Please.
but then, you know, creating a continuum of care services. I mean, that would be a separate budget item, but just for the
No, I
naloxone.
understand. I'm just thinking that we have the luxury here to ask this question. And, you know, in psychology, there's the primacy effect and the recency effect. Sometimes people are affected by the first thing they heard and disregard everything else, and sometimes people hear the last thing and they're only influenced by that. I have to tell you, I'm being affected by the recency effect. I can't see how, after hearing just already what you've said, reminding us of what most of us probably knew, that we can't elevate what we're talking about to partly the top of our list. I'll get to you, Ashley. I really want to follow up with this. So is there anything more that you would like to say about, well, just what it would mean for New York State?
Steve, I have a question, and it actually adds on to yours.
Ashley, go ahead, please.
So, and it has to do with continuum, because they have both talked about continuum. So to adequately fund doesn't just mean the naloxone. So I mentioned that I had gotten letters from people that are afflicted. So something that we are lacking in rural communities also is syringe exchange services. So what would it look like if you properly also funded those, right? And that's where we're getting those other models where people are getting support, where they're getting peer services, where they're being connected to other services, right? And so I would question you both, like, what would that look like to New York, like Steve said, and also, you know, what kind of money and investment would it take? Because I know that people are saying, okay, like we have a mobile one for Project Safe Point that goes to Troy, but they only come once a month, even though you can walk down the streets and watch needles float down. Or they're being told to clean out their needles with bleach. So if we're truly gonna invest, I think that that's also important.
Yeah, I appreciate that, and I guess hidden in my question was the answer. I think the answer to the question is that if we fully invested in what we know works and followed all the tentacles across the continuum, we would radically affect the mortality rate in the state, which is why we're here. So I'm just thinking, you know, I want to hear the rest of the presentation, but you know, the evidence is quite clear that these are the kinds of things that we have to look to when we prioritize, and we could radically change the health of this state by following the arrows here.
So I would just like to know what the professionals money-wise, what that would look like.
Well, actually,
Can I just ask one, because you said continuum of care, so and to your point as well, when I talk about presentations from OMH, from DOH, and from OASAS, you know that I'm looking towards integration of services, meeting people where they are, strength-based system. And so I am also very interested in what we can do for people who are revived using naloxone to be able to connect to a system that would better meet their needs. Because I, quite frankly, some people are very hung up on, is it the same person 10 times? I don't care. If we're not giving them the services they need, we're going to keep them alive until we collectively build that continuum of care. So I'm curious how that...
We really have to let Joanne finish, so can we do that, and then we'll come back?
We had Alan on for continuum, so...
So,
Can I-
go ahead, Alan.
I just respond just to Stephanie and put it into context. I mean, there was a conversation yesterday about people going in and out of treatment. The harm reduction programs are the safety net for people who use drugs in New York State. They've been underfunded for a very long time, and they can do more. So every piece of the conversation that we've had in this room yesterday, you can slip it into the harm reduction conversation. So our programs can provide mental health care. People who are suffering from substance use disorder can get care and treatment through our harm reduction programs and be referred to OASAS licensed treatment programs. They can get mental health care programs and be supported in a transition to a licensed mental health program at another place, or you could do it within that safety net. We know the medical system is not friendly to people who use drugs. In fact, it kills them. And when you ask people who use drugs, where would they rather go? They say they would rather go to a harm reduction program than go to an emergency department or be admitted into care through the medical system. You can ask them about all systems of care that they've been presented with. It's not that they don't conform to the system. The system does not work for people who use drugs in New York State. And you see that in the toll the overdoses taken for people who use drugs in New York State. And harm reduction programs start with a baseline of we serve you. You are not conforming to us. We do what you need, whether that's clothing, food, showers, mental health services. There's a recognition that people, when you walk into a harm reduction program, the fact that you use drugs is off the table. You use drugs. What is it that you need? In the old days, it used to be HIV. Everyone, you accepted that, and then you can deal with the trauma. You can deal with the mental health crisis. You can deal with the basic needs. And as Joanne's mentioned, social determinants of health underpin our response to that. You go to the programs and you see people sitting in the drop-in centers, and they've got a respite there from the street. They have nowhere else to go, and they turn to these programs because these programs are willing to support them. They are the safety net, and if we had the ability to expand that care, that is what we create in our continuum of care. You know, we think of prevention as a way of stopping people who use drugs. You prevent them, you slow it down. You have treatment at the other end where people who need to stop using drugs, that's their out if it works for them. But we have so poorly invested in the people most at risk of dying or getting diseases, and that's people who use drugs, and that's where harm reduction fits in.
Alan, thank you so much. Thank you. Joanne?
Well, that's a hard act to follow.
So the question, and Steve, you said you don't want to talk about budget, but I think maybe we need to know a little bit something because it's such an important program. So Alan or Joanne, sorry, I forgot your name. What would you think will be an adequate amount that you will need to make sure that you're providing safety for the rest of the state?
So I'll follow up on the comment I believe Alan made earlier, that recognizing the purchase of naloxone is one part, the surrounding services that assist individuals following the overdose is an additional and significant part. If the cost in the last year was $13.5 for the product only, Alan, I believe, made reference to between 16 and 18 million dollars to provide additional supports.
That's just for naloxone, Joanne.
Oh, that's
Just
just
for
for naloxone.
naloxone.
Okay, so the reason why I think that giving a definite number is a bit challenging is because so much of the work that we do, for example, if someone were to experience an overdose and there was a drug user health hub within that community, the health hub, which is also funded by New York State, would be part of that person's support system following the overdose. So the dollars are all linked, right? And it's the continuum. I think it's
Yeah.
challenging to say a specific dollar amount, but what I can point to with complete confidence is that we know we spent 13.5 million on naloxone alone within the last budget year. So
But
we
there's a
know
lot that goes into it besides the naloxone.
Exactly.
And we all know that, you know,
Exactly.
there's the treatment, there's the counseling, there's all that stuff.
Joyce?
Okay, so, you know, I sent everyone, just as a point of information, that article that my colleague and I published in the peer-reviewed journal, the Journal of Substance Abuse Treatment. I would really recommend that you all read it because it goes into depth into what a harm reduction agency provides. So, and that article was written quite some time ago. For the price, what I think for a fully funded harm reduction agency that would work 24/7, 7 days a week, where we provide the full continuum, and we are not Medicaid funded. Just to tell you, we scrape by every year. It's really hard for our agencies. Our budgets are just really, we are just have perennially, chronically underfunded. But if we really wanted to support a harm reduction agency throughout the state and want them to work 24 hours a day, 7 days a week, and you would need a minimum of about $4 million to $5 million for those agencies. Dividing that by 3, that would be something like 1 point something per year for each shift, understanding that the later shifts would require more money. So I think that that's a pretty, that would sort of help us build the type of capacity to provide all of our communities, you know, 24-hour support. You know, a lot of our people, you know, if we can only work from 9 to 5, and our agency closes at 8 p.m., what happens between 8 and 12 midnight? What happens between 12 midnight and 2 o'clock in the morning, or between 2 o'clock in the morning and 6 o'clock in the morning? And, you know, people are waiting at our doors so that they can get in and get, at our agency, you get everything. You get breakfast, lunch, and dinner. You get everything. Read my article. I think it's important for you to understand what a continuum of care looks like and how hard it's been for us to patch it. And I know that DOH has been patching up. Just to answer you, Justine, I'm sure that there's a lot of patching up in that budget that it's just really hard to get to, and urge you to move
If
on.
I could just respond, and again, thank you, Joanne and Alan, very, very